Okay, so hi everyone, and thank you for your patience, and thank you so much for joining us with the post-ASCO webinar with Dr. Omid Hamid from the Angeles Clinic and Research Institute in Los Angeles, California. Dr. Hamid will present on learnings from the American Society of Clinical Oncology Conference with a focus on skin cancer and melanoma. My name is Luke Bernard, Assistant to the President of the Save Your Skin Foundation, and I have the pleasure to introduce Dr. Hamid to you today. Omid Hamid, MD, is the Chief Translational Research and Immunotherapy at the Angeles Clinic and Research Institute. Dr. Hamid also serves as the Director of Melanoma Therapeutics. Dr. Hamid's area of expertise include immunotherapy and phase 1 drug development. He is recognized as a key opinion leader in immuno-oncology drug development and melanoma therapeutics across the United States and internationally. Dr. Hamid has also presented research done at the Angeles Clinic at major national and international meetings such as the American Society of Clinical Oncology and the Society for Melanoma Research. Dr. Hamid has also been extensively published in prestigious journals, including the Journal of Clinical Oncology, New England Journal of Medicine, and Clinical Cancer Research. I just want to thank you so much, Dr. Hamid, for joining us today. And also, just before we begin, thank you. Just before we begin, I just want to make a quick note that there will be a question and answer portion after the presentation for those who have questions. And you'll be able to see there on the side of your screen a question box, and please feel free to type those questions in there as they come to you. And but without any further delay, I can hand the floor over to Dr. Hamid.
Thank you for that lovely introduction. I'm pleased to present to you some of the data that was presented at the American Society of Clinical Oncology just a couple of weeks ago. It was a very fine meeting with a very interesting and up-to-date data. Some of the stuff that we've been waiting years for, which showed the long-term benefits of therapies that we've had, which showed the way the field is moving, which hope to answer some questions on how we can monitor patients with melanoma on their therapies, and also what to do for those patients who have a need for other types of therapies and have exhausted standard therapies. It was a great session for melanoma in the orals and the posters, but also in the immunotherapy portion, the developmental therapeutics. And now what you're starting to see is some of the work that was done in melanoma trickling into other solid tumors. So I'll begin. Here are my, let's see if I can't get my, here are my disclosures. It's interesting to see that we have more and more companies working with us in immuno-oncology and for our melanoma patients. I'll start with something that's very timely, since BRAF and MEK targeted therapy was just approved by the FDA for lung cancer today. You'll realize that this has been in melanoma for an extended period of time. And Jeff Weber presented 5-year survival updates from the initial phase 2 trial of a BRAF inhibitor, Dabrafenib, and a MEK inhibitor, Trametinib, in patients with mutant melanoma, unresectable or metastatic. This was the part C that looked at what is now the standard Dabrafenib and Trametinib dosage versus a lower dosage versus what is now not standard, just a BRAF inhibitor alone, allowing crossover. And we know that this is not the right way to move forward. We know to start patients with the combination. What was interesting now is that just like with immune therapy, we're seeing that targeted therapy for patients with BRAF mutation are showing long-term survivals that are significant. And you're seeing here a survival curve between the arms, and the orange one is the one of interest, and the green, those are the combination arms, where you're seeing 48 months and 60 months survivals with combinations somewhere around 30%. You're seeing a tail of the curve and a plateau, almost similar like immunotherapy. So targeted therapy giving long-term survival for patients with melanoma. We're also trying to figure out who does better and why they do better in these therapies, and this is looking at LDH levels. And lower than upper limit of normal LDH, you can see here, those are the patients that did the best. If you have a low level of LDH, you can see 5-year survivals of almost 45%. So we're trying to tease out those patients that would do the most, the best, and maybe less than 3 metastatic sites. Again, those are the ones that do better. In conclusions, this was the longest follow-up, showing long-term survival achievable not just with immunotherapy, but with combination targeted therapy to BRAF and MEK. You're seeing 5-year overall survivals with normal baseline and less than 3 organ sites with this combination at 50%. So we're teasing out who does better and why. But not to be left behind, Carolina Robert showed long-term survival of a first-line trial of Keynote-6, which was Ipilimumab versus Pembrolizumab. This trial showed the first-line activity of Pembrolizumab, and this led to the approval in first-line. What was important here is in follow-up, we're now looking at 3-year survivals being 50%. So wonderful long-term survival that's continuing for these patients. This trial had patients stop therapy at 2 years. So if you had a complete response, or if you had partial response or stable disease, you got to 2 years and you could not get any more dosing and you were monitored. And you can see those patients who aren't getting dosing, the blues are the responders and the pinks are the stable disease patients. They're all continuing to respond and have stable disease. You're seeing patients become complete responders down the line even after they stop therapy, and patients getting partial responses, and of course some small progressors. But what's important here is the beginnings of understanding about how long we have to treat people. We can tell patients that they don't have to be on treatment for many, many years. You can see here that these patients stopped at 2 years and are continuing to do well. We also saw that in progression-free survival, this line is showing those patients who had a complete response in blue or partial response stay in complete response and partial response, 91 to 95%. And those patients who have stable disease, 80% of them 10 months out are still having benefit. So we're understanding that after a median follow-up of nearly 3 years, we're seeing great safety, overall survivals, and 91% of patients who discontinued Pembrolizumab following 2 years continue to be progression-free. So more and more understanding about how long to treat. Here are those patients that was the long-term follow-up. What we're also looking at is newer combinations of newer drugs plus a PD-1. This is Epacadostat and indolamine deoxygenase inhibitor, plus Nivolumab, which is a standard in patients with advanced solid tumors. I had the pleasure of being a senior author on this, and this trial presented its melanoma data. It's important here to understand that combinations are becoming the standard for first line and for progressors, and there are multiple combinations out there. This is one that has shown significant ability. IDO is an enzyme that is secreted in the tumor microenvironment. As you can see here, it increases Treg cells. We don't want that. It inhibits the T effector cells. And what happens is IDO changes a immune environment into an immune suppressed environment. This changes tryptophan through the kynurenine pathway. So depletion of tryptophan and production of kynurenine shifts the local microenvironment into an immunosuppressed state where PD-1 inhibitors may not work as well. So you give an enzyme inhibitor like Epacadostat, you may make that area better and you can get better response. And here, this is the objective response in patients treated with melanoma, treatment naive, so first line. And you can see here response rates in 40 patients, 63%. Now these are 40 patients, a small number, but you can see the response is better than what you would expect with PD-1 therapy alone, which is somewhere around 30 to 40%. And about 88% of patients had benefit of control or better. So this is something that's moving forward. These are waterfall plots that show how much of the disease resolved, and you can see there are patients that had all of their disease respond. These are spider plots, and you see these lines that are coming down showing a fast decrease in the amount of tumor, and the fact that these lines stay below 0 and continue a long-term control, almost a year or more. So early data, we've already looked at epacadostat with Pembrolizumab, and there's already been a randomized trial. So interesting stuff with ongoing responses and benefit. What we're trying to do is to be able to work and take care of our patients, not just blind leading blind, but understanding what tumor markers, what's in the tumor microenvironment, and how to take one patient and say, you need combination, you need single agent, etc. So you can see with epacadostat, you might want to look at the levels of IDO in the tumor microenvironment, and if it's high, treat that way. But we also have other checkpoints to combine along with those checkpoints that we're familiar with, like CTLA-4 and PD-1. So all of these checkpoints, those that turn up activation of the T cell on the left, and those that block the inhibition of the T cell on the right, are being looked at as single agents and in combination. OX40, GITR, CD137 have been in my clinic for an extended period of time and in combination. And TIM3 and LAG3 are those that, if you block them with antibodies, you can block inhibition and stimulate the immune system. Bring your attention to LAG3. Yep. As we go forward, sorry. As an aside, we're also combining immunotherapy with targeted therapy. This was presented by Ryan Sullivan. And you can see here, putting combination immunotherapy and targeted therapy showed 100% disease control that is durable and long-lasting. This is what I wanted to show you also. That not just that combination that you looked at here with the BRAF, but combinations of checkpoint are feasible. They can have low toxicities, as we're seeing with epacadostat and PD-1 therapies. But this is a combination looking at LAG3, which I just showed you, in combination with Nivolumab, the anti-PD-1 inhibitor, in patients who've previously treated with a PD-1 therapy and failed, and their tumors grew. And what we did here is we took anti-LAG3. It regulates a checkpoint pathway that inhibits activity of T cells. And we blocked LAG3 and PD-1 together with this BMS drug and Nivolumab. And we're looking at how much that gives us in patients who stopped responding to just PD-1 inhibitors alone. So this combination was looked at by Paulo Esierto, who presented this data. And you can see here, they didn't see a complete response, but they saw partial response in 6 out of 48 patients, 13%, and stable disease in another 42%. So 55% of patients benefited by just adding a LAG3 on. When you look in the tumor and you look at LAG3 expression, you say, which are the high expressors and which are the low expressors? How much LAG3 is there to inhibit? You can see that a greater number of patients benefited in those subsets with high LAG3. So you could take tumor tissue and see if this is overexpressed and say these patients can go on this combination. So that's wonderful. And you can see here that the response based on LAG3 expression here is very important. let's go back a little. So you see here the response rates are increased. All right. So you can enrich for anti-tumor activity in patients who express LAG3 on tumor-associated immune cells. But you can take this idea and look at IDO, OX40, CD40, and find the right combination, and that's how we're going forward. The other point that was made by a lot of presentations is, how can we really tell what's going on before we need to do a CT scan or before we need to do a biopsy? And liquid biopsies are a novel diagnostic that can help us. If we can analyze tumor material, tumor cells or tumor DNA, obtained in minimally invasive or non-invasive manner, like a blood draw, we can look at this longitudinally. That means at day 1 and day 10, day 30, etc., and look at that. So these circulating tumor DNAs are like a liquid biopsy for cancer management. You can look at when a patient starts, take their blood, look at the DNA clones, and when it gets long, change your treatment to bring this down. And then when things change your treatment to target the change. And this was presented. You looked at circulating tumor DNA in patients, and we're able to look. This is looking at baseline and as weeks go by. And those patients who had low levels, undetectable circulating tumor DNA, and remained low, so green to green, or had high levels, high red, magenta, burgundy, high levels, and then as treatment went, became less, or as treatment went, they became negligible, those patients had a favorable DNA profile and did well. They responded. They were the patients who were, when you looked at them, either they responded or they had pseudoprogression, where they looked like they were growing, but they really weren't, so you continued them on therapy. So we use this to know if patients were really progressing or not. If the CT scan showed growth, was it just short-term growth and then response, or continuing to grow? And what we also were able to do, and this is a little more difficult, but those patients who responded here in blue, and those patients who progressed but had a favorable circulating tumor profile, they did almost as well as each other. And those who progressed and had an unfavorable DNA profile, they did poorly. So you can sort of be able to tell patients, well, even though the tumors are growing, you're doing really well, it's working, let's continue, or let's add something, or say this therapy is not working, let's move on to something else. I took this slide from James Gully, who's from the National Cancer Institute, and he presented he presented data, but he presented this slide, which I liked. And this is telling us about immune therapy and what's going on. That we are now going to have to look at it as multiple layers. What else, other than just anti-PD-1, anti-CTLA-4, do we need to bring in? Are there nutrient-depleting enzymes like IDO or arginase? Well, we have things that target that. Do we have to use PD-1, PD-L1 along with anti-CTLA-4? Do we need to use other types of immune therapy or even targeted therapies? And that's where we're going now. As you can see, those presentations led from the initial BRAF-MEK paradigm, or the initial anti-PD-1 paradigm, and then said, let's put them together and try to do more. And we've seen that, higher response rates. But now we have to understand who needs what type of therapy, or at progression, who needs combination therapy. What's also left is adjuvant therapy in melanoma. And there was lots of discussion about the standard. What we have found out is Ipilimumab, anti-CTLA-4 therapy in the adjuvant, has led to better survivals. 11% greater patients doing well at 5 years. But it comes with toxicity. So there are multiple clinical trials ongoing now, and accrued that we're looking to find out the answers. These were not presented at ASCO in a way where we could say one is better than the other, but Pembrolizumab versus interferon, that's accruing. Pembrolizumab versus observation. Nivolumab versus Ipi in the adjuvant. These have all accrued, and you can see the numbers here are astronomical, 3,000 patients or more. This trial is just opened worldwide and here at the Angeles Clinic of Nivolumab plus Ipilimumab versus Nivolumab alone versus observation. I'm sorry, this one is open. This one is open at the Angeles Clinic. It's Nivolumab and Ipi versus Nivolumab versus Ipilimumab. And then the BRAF targeted agents, they've already accrued. We're looking forward to hearing about these and their survival benefits in the near future. What we're looking for are therapies that don't have toxicity but can help patients do well so that we don't have to deal with long-term treatment, metastatic relapse, which is fraught with toxicity and morbidity. Brain metastases had a huge part at ASCO. Melanoma brain metastases are common, and what we usually use is surgery and stereotactic radiation, just radiation, but they don't impact survival and disease in the other areas of the body. So this is a critical need. And at ASCO, there were some answers. This is the combination of Nivolumab anti-PD-1 plus Ipilimumab anti-CTLA-4. It was presented by Hussein Taubi, and we had the opportunity to be involved in this trial. These included patients who had brain mets, who did not need acute radiation or surgery. And this is the type of patient that would come on. We treated them with the combination as we would regularly. And what we saw here is response globally, intracranially in the brain and extracranially in the body, where response was seen 50% in the body, 54% in the brain, an extra level of stability also. So about a response rate somewhere around 50 to 53%. The clinical benefit around somewhere around 60% in the brain and 52% in the body. And patients like this is the man that I showed you, did not have surgery, did not have radiation. At baseline looks like this, but after therapy looks like this. And in our clinic, we've seen that. And the important part here is, look, this is a year. These patients with brain mets would not do as well if we could not have controlled it. So the combination immunotherapy becoming standard in brain mets is what I see happening. So clinically meaningful efficacy, and with 9 months of follow-up, a response rate of 55% in the brain, and 20%, a fifth of those patients who go on trial achieved complete response. And they continue to respond. Well, what about BRAF-MEK? And this was presented by Michael Davies. We knew that BRAF therapy alone has control in the brain and in the body, but you can see here intracranially only about 40%, and disease control about 80%, but the responses are low. And this took the combination of Dabrafenib and Trametinib and showed a higher ability to respond in the brain. And that's important for symptomatology. So this is the first report of BRAF and MEK in patients with brain metastases. And so what that means is we use that for multiple patients in our clinic who need a therapy for brain mets. And in the past, we were without benefits and without therapy for these patients, and now we do have therapies for these patients. We've also found that re-challenging with BRAF therapy can work, and this was shown. Patients with prior BRAF inhibitor were re-challenged, and we got responses and durable responses. So once you've run out of options, you can come back to some options that we've had. Well, as we've talked about that, we also want to be able to evaluate tumors in a better fashion. This was not presented at ASCO, but is a trial that's upcoming. Looking at antibodies with mini-body that target T cells that can be injected in patients, and this is in an animal model. They can go directly to areas where there are T cells, and they can help us to know if the T cells are going to areas where there are tumors. This looks like a PET scan. It is, but it's a PET scan that lights up not for tumor, but for T cells. So if those T cells look like they're at the same place as the tumor, we can expect a better response than if we image and we don't see that. So this is upcoming and will help us to optimize to see who responds or who doesn't respond, or whether combination therapies are working. And as I end, this is where we're going. We're trying to find a way to take a patient and evaluate the tumor, see if it's inflamed or not inflamed, what's happening in the immune system, and be able to use our therapies early on or when there's progression to find the right combination. Look, this is the anti-PD-L1 plus IDO inhibitor. This is what I showed you with Efficacy, right? This is one with other checkpoint inhibitors. This is what I showed you with anti-LAG3. And we have more and more. Here is patients with no identifiable immune targets where you need to improve the immune system. So you add it plus chemo or radiation or targeted therapy with BRAF MEK. So all of this is coming to fruition. What ASCO 2017 showed is that we have the ability to be able to improve our responses early and late for patients with metastatic melanoma, that we're making headway, not just in the metastatic setting, but in the adjuvant setting, and not just in patients who have body disease, but in the brain. And we are finding new targets. And what's interesting is these trials are now being moved from melanoma and helping patients with other solid tumors. I'll skip this. And with that, I will thank you for listening and go from there.
Absolutely, Dr. Hamid. Thank you so much for that presentation. Of course, now we can open it up to anyone who has any questions. And we do have a quick question here from the audience. It's just asking or referring to the process of availability of liquid biopsies coming for melanoma specifically. So example, blood test to monitor melanoma.
So it depends on where you're working. It's now experimental, but it's maybe moving further and further into the mainstream. There are places that do circulating tumor DNA. It's not a standard right at this moment.
Excellent. And Dr. Hamid, in listening to your previous post-ASCO presentation, you mentioned that you were interested or excited about new treatments that were going to be coming down the pipeline. Did you see any of those come to fruition at this year's ASCO?
Yes, Efficacy is something that's already being looked at in a phase 3 study. And if it shows benefit, yeah, it'll come to fruition. It'll move forward.
Excellent. And also, too, just one last question here. It's more on the, of course, your role is for the treatment for skin cancers and melanoma, but especially with your team being there, located in California, do you see any preventative measures or anything new that has changed recently for you there?
So preventing melanoma is all about sun exposure. It's all about a healthy lifestyle and no tanning beds, etc.
Absolutely.
Okay, guys, thank you so much.
Wonderful, Dr. Mead. Thank you so much again for your time. It's always a pleasure.
Alrighty, have a
All
good
right,
day.
take care. Bye now.